So now we're going to turn to the Alzheimer's state plan, well, actually the Alzheimer's Commission State Plan panel. We have Chair Laura Bowser, Summit Committee Chair Margie Shaver, Lana Sargent, who's the chair of the Data and Research Workgroup, Kim Kutner, chair of the Training Workgroup, Ishan Williams, chair of the Coordinated Care Workgroup, and I'll be talking about the potential new brain health and risk reduction.
Good morning. Come on now. Good morning. Has it not been a great morning? It really has. It really has. Thank everybody for the morning so far. And you know, someone said that Dr. Arovich did not bring a brain. I would argue that too. I think he brought a pretty darn good brain, and I just wanted to personally thank him for being here and his presentation. Our next session is focused on the Dementia State Plan and dementia capability. George has introduced our panel, and you'll be hearing from them a little bit later. And George is not up here, and George is supposed to be up here with us, so he will also be joining us. As you know, we're asking for your input into the state plan in the afternoon breakout sessions. We should have a slide, I think. Okay. And more on that at the end of the session. To help with that, we want to provide you with a brief overview of the goals of the plan. Thank you, George. We'll talk more about the development process in the final session today. You all have a handout in your bags where you can find the top level goals. We'll talk about what has been happening under the various goals to help give you an idea of efforts the plan has driven. But we want to encourage blue sky thinking in the breakouts. Let me say that again. Blue sky breakouts. Blue sky thinking in the breakouts. Who better than you to tell us what is needed to help make Virginia fully dementia capable? But first, let's get everyone on the same page about what that means. One more? Okay. Thank you. I know this slide is a little wordy, but at heart, dementia capability is about having agencies and a workforce that have the skills to identify, work with, and provide appropriate referrals and services for people living with dementia and their caregivers. It is also about educating people on dementia, different dementias, brain health, and dementia risk factors, and providing services to support people in their setting of choice. It also includes dementia-friendly initiatives. You can see that being fully dementia capable requires education, training, and awareness. It requires collaborative efforts within state government, between government and community organizations, and with communities at large. It also requires dollars. It will take advocacy and concentrated efforts to make this vision a reality. But we don't want to limit ourselves to what we think is doable. We want the plan to continue to provide a blueprint for a fully dementia-capable state. And you're going to help us get there. So I'm now going to turn it over to Laura, who's going to talk to you about the plan more broadly and goal number 1. Laura?
Well, thank you, Margie. It's actually hard to believe that we're already reviewing and revising the plan. For some context, this will be Virginia's 4th dementia state plan. The first plan was completed in 2011. And we've had many successes since then, but obviously there's a lot left to be done, and that's why we're here today. During lunch on the slides, we will actually have some of the successes listed out, and that's important to review before going into the breakout sessions, just so that you have that context. Our goal is to ensure that all Virginians living with cognitive decline have access to services such as care navigation or coordination, caregiver training, and support groups. Let me make sure I know how to work this. Okay. So on this slide, you'll see the 5 state goals. And on the handout, you'll notice that there's also potential goal number 6. We'll talk about that in a little while. But I'm going to spend the next few minutes talking about the first goal and some of the key accomplishments under that goal. And then my colleagues will talk about the goals that their work groups have focused on. So the plan's first goal is to coordinate quality dementia services in the Commonwealth to ensure dementia capability. This is focused on services provided by the state, such as Medicaid, interagency cooperation, and collaboration to support Virginians living with dementia, ensuring dementia capability of relevant services and workforces, and maintaining the Dementia Service Coordinator role, which George serves in. The first recommendation of the first Dementia State Plan in 2011 was to create that role. It was funded by the General Assembly in 2013 and was crucial to helping move the plan forward more broadly. Just so that you all know, we were one of the first states to actually incorporate that role, and now over 30 states have a similar role, as they recognize the importance of having someone whose job it is to focus on improving quality of life for people living with dementia at the state level. Other successes, and I am reading y'all because it's a lot of information and I don't want to leave it out because it's important. Other successes that fall under Goal 1 include the creation of the Healthy Brain Virginia webpage in 2017 by the Virginia Department of Health with the support of the Dementia Service Coordinator. This has since grown and been replaced by the Brain Health Virginia webpage created by VDH in partnership with DARS and the Alzheimer's Association. That was supported by funding from the CDC Bold Grants. Virginia was one of the first 5 states to receive an enhanced grant under this program and recognition of prior work and existing structures, notably the existence of the Alzheimer's Commission and the Dementia State Plan. The Dementia Service Coordinator has partnered with Leading Age Virginia in the effort to promote and grow dementia-friendly initiatives across the Commonwealth. Since launching that effort in 2018, around 8,000 people have attended the free 1-hour Dementia Friends information sessions, and the number of dementia-friendly communities aligned with Dementia Friendly America has grown from 1 to 10. That's covering 1.5 million Virginians. An early project that the Dementia Service Coordinator completed, and which is updated periodically, is the list of comprehensive dedicated memory clinics that serve Virginians located within the state, or neighboring states as well. As new memory centers are formed, they'll be added to that list. You can see another accomplishment that we're very proud of around you today, actually, and that's the Dementia Capable Virginia initiative that brings all of our resources together under one recognizable brand, and you can see it right there on the panel. These include the Dementia Roadmap, which you have a copy of, the Primary Care Dementia Practice Toolkit, and other resources for family and professional caregivers and community-based organizations. I'd also like to mention the Dementia Service Workgroup led by the Department for Behavioral Health and Developmental Services in 2022. This work group was focused on the issue of people living with dementia who end up in state psychiatric hospitals. This is still obviously a very long-standing issue that remains to be solved, but the work group has fostered new collaborations at the state and local levels to address this and similar issues around behavioral challenges related to dementia. And finally, a great success is the imminent expansion of the commission itself that you heard Commissioner Hayfield speak to earlier. It's crucial that we have systemic collaboration between the key agencies in order to make progress in all this and other dementia-related issues in the state. And with that, I'm going to turn it over to Lana Sargent, who will speak to data and research goal number 2.
Yeah. Hello, everyone. Good to be here with you. How many people like data? Raise hands. Woo! All right. You can keep your hand up. How many like research? How many like data and research? Yeah. All right. So I get the honor of talking about 2 goals, but they are great goals. And as if you're joining us for the work group, you're going to be helping us, as Laura said, add to these and think big about this. So goal 2, there we go. Goal 2 of the state plan is about using data to improve public health outcomes, right? Data, if it comes from the right place, can be really powerful. So when the commission updated the data state plan in 2019, one of the areas we tried to work on and adopt was a broader public health approach to dementia. And as you already know, Alzheimer's disease remains the 6th leading cause of death in the US and in Virginia. And we still know that it is one of the top 10 causes without any disease-modifying drugs or a cure. Although we've made some significant strides in the past year, we're still working. So if we're going to take the traditional 3-phase public health approach, it involves primary prevention, that's what we've been talking about, so that addresses risk factors and proactive awareness. A secondary prevention approach, which is early diagnosis and detection and follow-up care, and a tertiary approach, right, which involves active management of dementia and improves the quality of life of people living in Virginia with dementia and their caregivers, right? To implement this effectively, it really requires identifying and developing new sources of data. Always looking for new sources of data. So that's why we need your minds today thinking about what are we not thinking about that we could use. And then improving that data collection and improving the use of that data, right? And we want to do that both in the community and all throughout. So efforts like the Virginia Memory Project, which is Annie in the room, if she can stand up. The Virginia Memory Project, which is aiming to create a statewide epidemiological database, not for research, but for census, which allows us to track areas of hotspots or areas where service needs are the greatest. So this is a great example of some innovation that is really helping us get a good idea of data across the state. Work under Goal 2 also includes supporting periodic implementation of optional cognitive decline and caregiver modules, and this is in the Behavioral Risk Factor Surveillance System, BRFIS. This data, which we have used in the Commission and others have used, gives us insight to subjective cognitive decline and caregiver burden. And one of the unique aspects of what we've done is in this past 2 years, since 2019, we asked both the caregiver question as well as the cognitive decline question, so we can get a sense on whether or not caregivers are also experiencing cognitive decline, so we can cross-reference those factors. So another good example of what we've done for data is the CDC BOLD, which is building our largest dementia infrastructure grant, has supported the partnership between the Virginia Department of Health, DARS, and the Alzheimer's Commission and the Alzheimer's Association. This partnership is using data to inform education, awareness of brain health, and it's also addressing modifiable risk factors, which you're hearing a lot of talk about, and you'll hear more, through a public health system. So these are things like we've been talking about, chronic disease self-management, education is self-evident a part of this process, and programs that address some of the modifiable risk factors that help us reduce the prevalence of this disease. The DSC has worked to identify data sources to help us understand where the prevalence of cognitive impairment is the highest and provides insight into other dementia-related challenges, such as wandering. Unfortunately, as most other states, we still don't have a clear picture. We often struggle in our data work group to really understand the true prevalence of what we're seeing across the state. Initiatives like the Virginia Memory Project and the BOLD Act are hopefully going to improve this, as well as those who join us in the group to get us thinking about additional ideas to help us think about where else we can harness this data to help drive our work. All right. So turning to 5, I know we're out of order, but these two come together. Goal 5 aims to expand resources available for research, as well as to increase participation in research, increasing participation in research. I'm going to say that again, because that's an area where we're spending a lot of time trying to improve access to research. Opportunities for collaborative efforts by researchers. Successes here, things that we've done, have included changes to inform consent legislation in 2015 to allow people with cognitive impairment to participate in studies and to have that continued funding for the Alzheimer's disease and related funds, so RDRAF. Some of you may have reviewed for RDRAF, as well as been recipients of RDRAF funding. So it's very important for the progression of pilot grants that people want to turn into larger grants. This fund is managed by the Virginia Center on Aging at VCU and is a primary supporter of dementia-specific research projects in the Commonwealth. Over the last decade of years, our work group has been focused on ways to improve collaboration among researchers in Virginia. So who's doing the research, what's happening, how can people get involved, and to provide opportunities for learning and networking with each other. We're also looking for ways for how we can support increased participation in research by raising public awareness. So what is research, how can I get involved, and what is happening across the state. In particular, we'd like to support efforts for increased participation in underserved communities, so populations that otherwise are not represented in Alzheimer's and related dementia research, especially those with higher rates of dementia that we've been talking about today. To end that, we are developing a research area in the Dementia Capable Virginia website, so we'll be showcasing work that is happening across the state, and we'll be surveying the research committee. Hopefully, some of you guys will get our survey. It's coming out soon to see how the commission and the state agencies can best support these efforts. And with that, I'll pass it over to Kim to talk about Goal 3. I'll just advance the slide for you.
Thank you, Lana. Hi, I'm Kim Kutner with Riverside Health System on the Peninsula, specifically the Riverside Center for Excellence in Aging and Lifelong Health, now called the Martha W. Goodson Center. And we're going to go over Goal 3. There's a lot I could say about Goal 3, which is about increasing awareness of Alzheimer's disease and other dementias and delivering training to the public, to the workforce, and to caregivers, both family and professional caregivers. And I feel this is really important to me, not just professionally, but also as a personal caregiver. So starting with efforts to provide training opportunities to healthcare professionals, a federal grant was awarded to DARS, from DARS to DARS and supported what we did here at the Martha W. Goodson Center to create micro-learning sessions for primary care workers. So micro-learning is just like it sounds, 8 to 10 minutes of facts that can help support the practices. And as they watch them either on their computer or laptop or a tablet, phone, at their convenience. And everyone is short on time, family, professional caregivers. So that's been a training that's accessible to both professionals and family caregivers. The Commission compiled the Primary Care Dementia Practice Toolkit, which includes screening tools and links to training resources for those tools, practice guidelines for the primary care practices, including care coordination and follow-up care, and information about using billing codes for dementia-related services, which not everyone knew about. The toolkit takes a 4-step approach. There's screening, diagnosis, care planning, and referrals to services and support. Also, this is available on the Dementia Capable Virginia website. The goal here is to help support early detection and diagnosis throughout the state of Virginia and to provide the know-how that can help primary care practices become dementia capable. So brain health and dementia risk reduction education directed at both healthcare and the public at large has been part of the BOLD activities, utilizing ECHO and other means to ensure that physicians and the public have functional, practical information that can be used to support better brain health. So now moving to training for first responders and emergency personnel. The DSC regularly provides training to the Virginia State Police Academy, and DARS worked with the Department for Criminal Justice Services to develop a training on Alzheimer's disease for police and correctional officers. A bill passed recently, this year, that mandates that the training also include other dementias for this group, and that's important because we likely know that frontotemporal dementia, people living with frontotemporal dementia are more likely to have an encounter with the police than people living with other dementias. So next, a lot has been done in the caregiver, trainer, and education space over the last few years. DARS utilized a federal grant to develop training modules directed at area agencies on aging team members to help them become dementia capable. They're also available on the Dementia Capable Virginia website. Other grants have helped bring evidence-based programs to family caregivers, such as Families program that utilized the New York University Caregiver Intervention, and the Rosalind Carter Institute's Dealing with Dementia workshops that are rolled out in many areas of the state starting in 2020. At Riverside, we created another series of micro-learning education to help family caregivers with their self-care, and we called it the Caring for You, Caring for Me, Mind, Body, and Soul, taken from, based off of the Rosalind Carter Institute program, Caring for You, Caring for Me, which my colleague Dr. Jensen is a master trainer of. These modules are made available initially through Virginia Navigator's caregiver education platform and now can be found on the Riverside YouTube website. There's a large number of other organizations providing other caregiver education and training support, such as Piedmont Dementia Education Committee, the Northern Virginia Dementia Care Consortium, and the Alzheimer's Association, and many more. The goal is to provide a range of quality programs that will meet caregivers where they are on their journey. And finally, Virginia has been a leader in making Dementia Friends information sessions available. See the back table outside there for more information. Leading Age Virginia and DARS have trained more than 650 Dementia Friends champions to deliver the information sessions since 2018. And as you heard earlier, around 8,000 Virginians have attended those sessions. They've been offered to high school students, faith communities, state employees, and many other groups in an effort to raise awareness and an understanding about dementia and reduce the stigma that surrounds it in the broader population. And now I'll pass the mic to Ishan.
Thank you so much, Kim. So care coordination for goal, we're talking about goal number 4. Care coordination is at the heart of the state's plan's vision for supporting people living with dementia and their families. I should say who I am, right? My name is Ishan Williams. I forgot to introduce myself, and I'm a faculty member at the University of Virginia in the School of Nursing and also do work with the Department of Neurology. So now, back to the care coordination. The Agency for Healthcare Research and Quality, or AHRQ, notes that care coordination can improve outcomes for everyone, including patients, providers, and payers, and has developed quality measures to help organizations monitor and improve their efforts to provide these services. Studies have shown how care coordination can help improve the quality of life for both the person with cognitive impairment and those supporting them. There is also evidence to show that care coordination can help delay the need for moving people from their homes to a long-term care facility and can help reduce hospitalizations and emergency room use. Providing caregivers with knowledge, skills, and direction can boost their self-efficacy and enable them to confidently care for their loved one for longer. It can reduce depression and anxiety for both the caregiver and the person living with dementia, and it can help reduce the perceived severity and difficulty of behavioral challenges related to dementia. It is so exciting that there are several different approaches to care coordination being used around the Commonwealth. Both the University of Virginia and Riverside Health Systems are using the evidence-based Benjamin Rose Care Consultation Program as the basis for their specialized dementia care coordination. Dementia care managers or navigators provide emotional and educational support for caregivers. They make appropriate referrals and connect families with services and supports to meet their varied needs. The results have been overwhelmingly positive, with some amazing stories of how the care managers creatively work to meet the needs of people they are working with. With the support of federal grants, UVA has been operating its program since 2016 and Riverside since 2019. With support from the Alzheimer's Commission, the General Assembly allocated state funds to UVA's program as a pilot starting in 2021. The Commission continues to advocate for making these services available locally in more areas of the Commonwealth. Meanwhile, the Richmond Brain Health Initiative is using federal grant funds to support the care ecosystem, another model of care coordination, and Carillion's Center for Healthy Aging in delivering care coordination services through its affiliated home health provider. Medicaid's Cardinal Care also includes care coordination as a required element for the program, serving those with both Medicaid and Medicare. Every person enrolled in Cardinal Care, not just those living with dementia, is assigned a care coordinator who helps connect people living in the community or in long-term care with the services and supports they need. And increasingly, health systems are realizing the importance of working in an age-friendly context focused on the 4 M's, which include mentation or cognitive health. Another state-level program that can help support people living with dementia remain at home is the Virginia Lifespan Respite Voucher Program. While this is not strictly speaking care coordination, the dementia care managers have added this to their toolbox and refer families to it to provide respite opportunities for our caregivers. This program at DARS is supported by federal funds and can reimburse families for up to $595 for respite care, allowing the caregiver time to do things they otherwise might not be able to do because of their caregiving responsibilities. The last thing I'll mention is the Primary Care Dementia Practice Toolkit that you heard discussed earlier. This includes tools and practice guides that can help guide practitioners as they start using the billing codes for care planning. The guides highlight the different potential areas of need that families may have, such as transportation, nutrition, home and personal safety, legal and advanced care planning, health, wellness, and social engagement, and caregiver education and support. And then it also offers guidance on how to connect families to services and supports to help them meet those needs. Embedding care coordination for people living with dementia across the healthcare system is a slow process, but it has been part of the vision of the Dementia State Plan from the beginning. And we are definitely seeing a lot of progress towards that end goal. More broadly, the Commission is encouraging funding for dementia care navigators that could be based in other community-based settings or organizations. These navigators could provide care coordination services in addition to offering cognitive screenings and referrals and community education on dementia and dementia caregiving. Okay, so much more that I could say, but let's move on to have George talk about elevating brain health and risk reduction within the plan. George.
Thanks, Ishan. So I know we're kind of running out of time, thankfully Bonnie Waddles and Dr. Arovich have covered brain health in a way that I probably never could. So I'm just going to say that if we address brain health and dementia risk reduction fully, we could help reduce the number of dementias by up to 40% at a population level. So since the last update of the state plan in 2020, the knowledge base around brain health and dementia risk reduction has grown considerably. But addressing brain health is not really a new idea. In fact, it's one of the codified powers and responsibilities of the Alzheimer's Disease and Related Disorders Commission. So last time we updated the state plan in 2020, we used the CDC's Healthy Brain Initiative as a guide to incorporate brain health into the other goals of the state plan. But with a shift in the National Alzheimer's Plan to include a new goal for brain health and dementia risk reduction in 2022, this was the first time they'd added a new goal since its inception a decade ago. And the BOLD Act of 2021 that has funded the BOLD grants, and Virginia was one of the first 5 recipients of the enhanced opportunity. It does seem fairly clear that we need to elevate brain health and dementia risk reduction efforts within the state plan. So to that end, the Commission and the Dementia State Plan Workgroup have been discussing what that might look like and is it actually needed. So we haven't made a decision yet. We know which way we're leaning, but we want to hear from you, the stakeholders, and the healthcare and service providers. We want to know what you think. Is it important enough to be its own goal in the state plan? With the last plan, brain health and risk reduction were included under Goal 2, which is the data goal. So recommendation 4 under Objective B of that goal, which states to collaborate with related public health efforts and encourage possible risk reduction strategies. That's the recommendation under that urged that the Commission collaborate with the Virginia Department of Health and local health departments to integrate dementia and brain health into public health strategies and reports. And that's the core of the BOLD Act grant activities. And with the hiring of a brain health coordinator at VDH and the relaunching and redesign of the Healthy Brain Virginia website, efforts are being made to achieve that recommendation. Sorry, I forgot to advance the slide. He's getting it. Okay. So efforts are being made to achieve that. A sub-strategy called for promoting awareness of the benefits of consulting healthcare for those experiencing subjective cognitive decline, as we know that only half of people who identify themselves that way have actually talked to a healthcare provider about their concerns. So more needs to be done. We need to prepare the primary care workforce to be able to respond appropriately and effectively. The second sub-strategy called for educating public health and healthcare professionals on sources and uses of reliable information about brain health and dementia prevalence. And we're working to do that through the brain health website as well as other ways. But that's the extent of it. That's all we talked about in the last state plan. So 4 years later, we realized that there is much more that should be done and that can be done to address brain health and dementia risk factors. But what do you think? Is it worth it? So come to the breakout session that's going to be covering that topic. It's a great opportunity to learn for us to learn exactly that, and how best to elevate it within the Dementia State Plan. So yesterday in our presentation at the Governor's Conference, and also this morning, you heard Bonnie talk about educating high school students and really focusing on youth, educating them about dementia and brain health, and how those students can reduce their risks of developing dementia in the future. So some efforts have been made, but more could clearly be done again. So perhaps that needs to be a recommendation or a strategy within the plan. And that would be particularly true where it concerns acquired brain injuries. As many people begin to acquire those injuries in their teens and 20s, early 20s. And we know that brain injuries significantly increase the risks of developing dementia later in life. Similarly, when people are told to manage their cardiovascular risks, are they being told that effective management of high blood pressure can possibly reduce their risks of developing dementia? And with dementia, older Americans' number one fear, perhaps that would help boost medication compliance. At any rate, you can help us decide how best to incorporate this knowledge into the state plan. So I'm afraid we don't have any time for questions, and we're going to eat into lunch in just a little bit because we have a video for you that's going to be 6 minutes. And a little, very brief instruction for the breakout session. So thank you for all of those of you who told us what your priorities were for the sessions. Fortunately, maybe, we're not going to be assigning people to breakout rooms, but each room only holds 30 people. And once that level is reached, we're not going to let anybody else in. You have to have a seat. It's like musical chairs. So make sure you get a seat. If you don't get a seat, you're going to have to find another room. But we do want to hear what you think. So everybody, if you do have input that you'd like to make on a different goal, you can maybe sneak out after 20 minutes, because we're dividing it into 2 bits, and move to another room. Or you can write down, so everybody's going to have a pink sheet of paper that you can write down your recommendations or strategies for the state plan. You can write about a goal that you're not in the breakout session for. That's absolutely okay. And there will be other opportunities to provide feedback into the plan, and we'll talk about those at the end of today.